Started with a little bit of housekeeping. In order to be more accessible, we have enabled closed captioning for this webinar. Look at the Zoom toolbar to turn on closed captioning in your view. You may need to click the 3 dots that say More to see the closed captioning option. Well, I would have liked to introduce you to our new executive director this morning, but it looks like she wasn't able to join right away. The Louisiana AAP is happy to welcome our new executive director, Natasha Cheatham. She is joining us from New Orleans and will be, I think, a great addition to our team here at Louisiana AAP. And we're excited to welcome her. Hopefully I will have a minute to introduce her at the end of the webinar. Okay, Dr. Troy and Mr. Cooper have no relevant financial relationships. Okay, without further ado, I will introduce our presenters. Dr. Troy works at the University of Holy Cross in New Orleans, teaching in the BSN program as an associate professor of nursing. Additionally, she works 20 hours a week at the Audrey Hepburn Care Clinic as a forensic nurse practitioner. She has been qualified as an expert witness in criminal court over 160 times. Her present research efforts are investigating the vicarious trauma to jurors serving in child sexual abuse trials. She has over 45 years of nursing experience in mental health. In addition to extensive review of pertinent research on gender-affirming care during the completion of his undergraduate studies, Michael Cooper has over 15 years of experience working with vulnerable populations such as the LGBT community through direct patient care and program management in community health clinics throughout the West Coast. His current employment in pediatric behavioral health has further highlighted the need for further research and implementation of gender-affirming care. I will now pass over control to begin this presentation.
Thank you, Julia. I'm going to be sharing this PowerPoint and making sure, can you see that?
Great.
All right, so we're very happy to be here today. As you heard from Julia, I work over at the Care Center. I've been very happy in my forensic nursing practitioner position over there, where I've seen thousands of children in the last 13 years. And this is implicit bias is very near and dear to my heart. It's one of the topics that the defense attorneys like to ask. What do we do in medicine and nursing to deal with our implicit bias? And having worked for 45 years, I started when in the DSM to be homosexual was considered a mental disorder. So I have watched the progression of mental health and our diagnosing and our ability to care for the vulnerable populations before us, and we're in a position of ever-changing. Research is ongoing on these topics, so it would be lovely if we were all in person and could really share and talk about all those things, but Michael and I are very happy to be here to share with you our experiences.
You might need to click the present button, Dr. Troy.
That would be very helpful. And where would I find that? As you can tell,
at the very top, there's a little picture of like a screen right next to your title at the very top of the page.
Right, Michael, you introduce yourself while I'm looking for that.
The other option is to click on slideshow, and then you should be able to present from there.
Okay, thank you.
Yeah. Along the top, there's animation, slideshow. Yeah. There you go.
Perfect. And then from beginning.
Yeah.
You think I never talked before, but I'm not used to seeing my bottom covered up. Excuse me, y'all. Go ahead, Michael.
Hi, I'm Michael Cooper. I am a recent graduate of University of Holy Cross in their BSN program. And since becoming a nurse, I've worked in postpartum care initially, because my background is pretty extensive in reproductive health care and women's health care. And then more recently, I've started working at Children's Behavioral Health Unit Hospital, or Children's Hospital, New Orleans Behavioral Health Unit. So, which was always my goal to get into that. And it's really been inspiring to work with the youth. Pediatrics is something that's dear to my heart, because in my community health life previous to nursing school, I worked at Planned Parenthood for many, many years. And so working with adolescents specifically around, reproductive health care and sexuality has been, I think, a good lead into the different kind of, almost crises, I would say, when it comes to our adolescent populations and the need for accepting care and gender affirming care. And I did all of my research in my undergrad looking into the barriers to gender affirming care and accepting care in the LGBT community. And a lot of it really came down to a lack of education from the provider side of things. So that's something that I've been looking to remediate with the help of Dr. Troy.
Well, thank you. And so our objectives today are going to be that as you learners will gain understanding of the concept of implicit bias. And I'm not aware of the extent of your training in that, but it really does relate to this issue in terms of our emotional responses as things are evolving. And that the learners will gain ways to address this in terms of care of persons of the community from LGBTQ. And the learner will identify resources for referrals to meet the holistic needs of the community and the ways that we interact. And again, if we were in the room together, I could have a better understanding of where people come from in their background and their knowledge of this, but just in terms of clarifying what some of the initials stand for, I've included a slide on that and will be very happy to share the slides with anyone who would like to see these afterwards. And so just with the AAP news, this is an issue that's very much in the forefront of the news as pediatricians are dealing with the political fallout and changing, ever evolving. And I just recently spent the week at the APSAC conference and was understanding through the attorneys in California who are now in Texas trying to ensure that gender affirming care does not get politically removed as an option. So when we're looking at gender affirming care, we want to look at the concept as encompassing more than surgery. It's really the medical, mental health, and non-medical services, and we're going to be covering those. The AAP has built a gender affirmative care model, which is out there for providers to help with making developmentally appropriate decisions for working with anyone in the TGD community. It originated in 2018 and then reaffirmed in 2023. So again, allowing that there be questioning and in a supportive environment, we all need to have some skills in language and ability to interact. And so and
I think, sorry, just to intercede, I think it is important to understand, I think we all understand on some level how politicized these issues have become. I was just looking at it before we started, and the ACLU is currently tracking 516 different anti-LGBTQ laws in the United States. And in the past 5 years, over 100 have come into actual law. And the 516 are legislation that they're tracking that may become law across the United States. So
it speaks to our, right, Michael, I have a responsibility to keep educated and to be able to educate those in the legislature. There's just recently been a decision in Louisiana that pedophiles or someone who perpetrates on a prepubescent child could be convicted and have as a penalty surgical castration, which completely underestimates the number of female perpetrators, and it is not a way that we can address this problem. So we see legislature and political action that's not being informed by what we in the forefront of this care are understanding. So right now, 2 out of 5 patients who are looking for care live in states where there's no access to care. In 25 states currently, we're looking at these changes in particular going to the Supreme Court, and that was what was discussed at APSAC. So anyone who is not familiar with the American Professional Society on the abuse of children would gain so much from the free education, the political updates, and the position statements. So they issued a position statement that just came out in March that gender affirming care is not child abuse, as was being proposed to the courts, in particular in Texas. And so we need to be apprised of what these things are that they're doing. So when we're talking about gender affirming care, primary care pediatrician would need to have some understanding of the fact that modalities of this include legal issues, social, in terms, and we're going to be covering some of these things in terms of pronouns, name, clothing style, and the ways of gender expression. And then what we've just been referring to as being withdrawn are the medical and surgical options that are not there. But when we take home points of this is that gender care is primary care and trauma-informed care is essential. And so as we are seeing kids at the Audrey Hepburn Care Center for evaluation for abuse, it becomes really something that we're dealing with on a regular basis. So there was also from lgbtmap.org, you can follow gender affirming care for minors as being outlawed where it is, which states are being impacted, and it's a way for us to stay involved, because if we, I heard an expression, if we don't have a seat at the table, then we're on the menu. And so, but I do feel like we would be remiss if we did not state that there is some dissension and that there's room for discussion. There's a wide variety of protocols for starting medical interventions. And I just put up here for reference that there's a Dutch protocol criteria, which is looking at extreme gender dysphoria, psychological stability, and family support as being requirements for receiving any of that medical treatment. And then variations of that in the UK. And then the WPATH criteria is in force since 2022, had a requirement of a long-lasting and intense pattern of gender nonconformity or dysphoria before starting puberty blockers. So they're even within the medical community. And I might say, I think it's important that we have these discussions without being attacked, and we can really understand what people are seeing empirically. So mental health or other issues were checked to see if they could compromise treatment adherence while treating adults with hormones. But again, when we start looking for young people in the US, 18 or older hormones are available even without a mental health evaluation, which is under informed consent. So some of the division even is within those practicing medicine. So we wanted to look at how do we get past our conscious and unconscious bias around these things? How do we get in a room and discuss things? I could feel the energy even at the conference. We were very much like-minded, and there was not a lot of discussion that would be contributing to someone's understanding or moving past a bias. But I wanted to just say that the goal for 2030 in healthy people is eliminating health disparities, and how do we get to that place, which is our goal. And so we know that unconscious bias are a reflex and can help us in some ways, but can be very burdensome in terms of our processing of what we're taking in information. But the Joint Commission has actually made a statement that we're all called to decrease this bias. So the ways of doing it are not simply saying don't be biased, but using emotional regulation. But if we can't talk about what we're thinking, and if we can't express what we're feeling with each other, then people just get into their silos or shut down or get angry and argumentative. And I've seen that in several settings, rather than sharing of ideas and really seeking after evidence-based information. So we need to do partnership building. So as we work with patients as equals towards the common goal of helping them achieve their optimum health, we do that in nursing and medicine. And perspective taking, I would just like to give a quick example of how I learned about that in Audrey Hepburn. When I first started working, there was a nurse whose daughter was being sexually abused by her boyfriend. And when the mom came in and I started telling her about what had been revealed to me by the teenager, mom's first reaction after hearing of ongoing sexual abuse was to cross her arms and just say, well, where am I ever going to find a man again at my age? And I realized in that moment that when we have these emotional responses of not understanding or not liking what we're hearing, that we haven't asked the right questions. And this has served me throughout the rest of my 13 years working with families with trauma and without trauma. But the idea of putting down my paper and saying, can you help me understand what your life has been like? And then she quickly described a mother who died of a heroin overdose, dad incarcerated, and you hear a long history of no attachment. And the only person she felt loved her was this man who I now said, no, he never loved you. He was raping your daughter. So within minutes of giving her history, she was able to focus back on her daughter. So again, when we're dealing with families and we see unsupportive parents, or we see people who shut down or want to move away or reject a child, we need to pause and take time and ask them to tell us about their lived experience. So a practice strategy or habit replacement, we have to focus on the present moment. And again, so I allow myself to have that feeling of discomfort rather than saying, I'm not judging her and I don't have any response to her. I allow myself to say, I'm having a response to her. And I ground myself in what's going on in terms of questioning my own assumptions, why am I thinking this way becomes very important. And then I analyze, I ask myself what's going on. And this again has to happen in the moment. So some of the analysis occurs in debriefing with peers or talking later about what was my reaction. And then again, speaking out and holding others accountable. And so when we start looking at implicit bias, one of the great things that I have my nursing students do is take the Harvard test, the IAT, implicit attitude bias. So you may be surprised at what you find in your responses. And so my students are often very defensive and will say, well, it told me that I have a bias, and I don't believe that I do. And again, it's just a starting point for looking at how quickly you respond to something. So what we know from psychology is that what you're conditioned to see or believe first, so in your home of origin, your socialization, the things that we've been exposed to, and even teaching these topics when I go home and I'm in certain family situations and the political view is completely different or skewed, you can find that you can have to be aware of these feelings that can arise in yourself. So whatever you're conditioned to see first, even if you're conditioned, so if you've seen this optical illusion, where do you see the young woman with her eyelashes and her necklace on and she's looking over her shoulder, or do you see the old crone with her large nose and her mouth is what you're looking at, looking down? The psychological tests have shown that what you're conditioned to see first will be what you go back to seeing. You can shift your gaze or paradigm shift to something else, but you will, if you're living consciously and aware, will be dealing with that. So what the IAT allows you to do is look at things like how quickly do you associate a bad word with cisgender or transgender people and good words. So you're hitting and typing as images come up. And you can do it with race, you can do it with weight. So you look at ageism. So there's a multitude of ways that you can gain some perception into what your unconscious is perhaps needing some recognition of. And the types of unconscious bias, as I told, one of the things that they ask me perpetually in court is my confirmation bias, so that I get a referral from law enforcement of a child who's been sexually abused. And if I could point out, please medically never put alleged sexually abused, because they will say to me, well, even the assessing doctor didn't believe it and said alleged. So we need to just put the quote of what the child's telling us or what the issue is. But that, again, we always go in and we consider alternative hypothesis. And so we can have an affinity bias where we hang out with people who are similar to us, which will keep us without being able to have a broader base, and we'll see things in, if you will, black or white instead of being able to see nuanced interactions. And then perception bias are the stereotypes, and then halo bias, even projecting positive qualities. And we see this when we start looking for physical abuse in children, that, you know, the middle class family from this neighborhood couldn't possibly have hurt their child. So again, implicit bias can exist for characteristics like disability, and again, sexual orientation, which we're talking about today. So to have cultural competence is a process and not an event. And so I'm doing this for 45 years. I still am surprised at the things that come up for me in terms of the things I need to work on, or the things that I learn about myself as I go through various experiences clinically, or just in the sense of being in care saturation and needing to take a break, but having awareness. And then today, hopefully building some resources for knowledge. And then the skills will be to trudge in to where you feel like you're uncomfortable and have these cultural encounters with a desire to do so. And so implicit bias can be as simple as just the roles that we consider, who you call when you're stuck or you have a flat tire, to who and what you feel about people who are transitioning in terms of sports teams. And one of the things that recently, I don't like to get into political things on Facebook, but it had been circulating, and unfortunately in my friend group, was the idea, if you belong in this bathroom for men and you follow my daughter and wife into this bathroom, you're going to need, and then having such an act of violence and misunderstanding and absolute ignorance about, and I had to respond to that, and I did so, and I educated people. And in the thousands of children that I've seen, the perpetrator statistically is the heterosexual, non-biological male in the household. And I have not, in those thousands of cases, ever had a transgender perpetrator. So we can hold different opinions.
And sorry, I wanted to, one thing that I think is always the hot button issue is the sports teams that you're talking about. and the supposed, ben the advantages
Advantages.
that someone would have. Exactly. I finally did look into it. That people who have transitioned and are performing, on a sports team that different than the sex that they were assigned at birth, don't outperform their peers in that, like they're not outperforming other female swimmers. You hear about the few that do extra well because of how politicized and how, hot this topic is in the media. But when you look at the numbers and take the time to provide that education, yeah, there isn't an advantage.
And I love what you're saying, because we want to get the numbers and we want to get to the truth rather than have people just say, well, that's not going to happen to my daughter, or we react again without delving into what do we really know, so we can compassionately care for patients. And again, it's the idea that we are able to, as human beings who are also care providers, that we are able to have our point of views and just provide for patients what they need. So here's some implicit bias examples of how we can fail. I stepped into the gynecologist's office for my appointment, and the receptionist said, you've got the wrong place. So it's not a matter of just knowing ourselves, but we have to make sure that those that we have at our front door, those that are greeting, and I know that Children's Hospital's made great strides to ensure that that is happening. Or I told my doctor I was trans after getting an x-ray for my sternum, and then all of a sudden they forgot how to care for a patient. And I know that I've seen that in nursing. When we would have patients who were transitioning, that everybody would want to know about the case or the patient rather than the human being. So when we look at according to the prejudice habit breaking framework, overcoming these habits of implicit bias are going to require learning about these contexts and having these open discussions. So some of the reading that I've suggested to my students, Caitlin Jenner's book, I really came away with a whole different sense of what her life had been like. And I am Jazz. And we need to look at these things because our patients are going to be. And so we want to be able to have some insight into if anything is misrepresented in it. So today we're just going to be looking at some of those ways of increasing our ability to talk to each other. So the debates on age to start doing the transitioning medically and surgically, and what will happen in terms of equality afterwards, as we're saying, are ongoing discussions that hopefully we can have. And then the other one was that when it came in for my strep throat to be cared for, they needed to know and wanted to know, and there's curiosity about what's gone on surgically. And I saw that with Caitlin, where that every interviewer talking to her wanted to speak about whether or not she had done it yet. So again, providing excellent healthcare for all our patients and learning and acquiring the information that really required for what we're doing, so we can stretch our comforting and care for them. And the reasons to do this, a person's identifying as LGBTQ are likely to rate their health as poor because they've assessed this as not approachable, understandable, or without judgment. And this idea that medical schools, I know Holy Cross, where I'm teaching, only a couple of years ago started addressing this issue in lecture and content. So I'm hoping that those of you who are on this will tell me that it's different. And I believe that we've changed the curriculum in schools. And one of the things that we look at the developmental, Rubel had talked about gender identity developing in different stages. Just looking at 0 to 5, we seek information and have norm violations and are corrected for those things. And we start to consolidate it, our understanding of what gender means between 5 and 7, and integrate it 7 and up. But we really need to have more research, and I've included something, common sequences of LGB plus identified developmental milestones. I was amazed to see the research that's looking at what is different and what is the path to romantic relationships in terms of attraction, self-identity, and coming out to others. So when we start looking why we need to do this, Michael's going to carry on from here.
Thank you, Dr. Troy. Yeah, so when we're looking at these populations, LGBT populations, I think that it's important to recognize just how vulnerable that they are. And I always like to start with it's the morbidity of the suicide rates, because that's what really struck me when I first started doing my research, is how this we're all talking about DEI training, and it sort of feels like kind of these soft skills that the corporations that we work for are trying to check their boxes, that we did our little online training for our DEI and call it a day. But I think what needs to be realized and recognized is when we're looking at the numbers, that this really can become a life or death issue. Like this, the rates, especially in adolescent populations of self-harm and suicide, are astronomical. And the fact that all of this illness, suicidality, self-harm, is coming simply from this societal bias and could be simply alleviated with accepting models of care, is a little frustrating, but also hopeful, because that's doable. That's an education, that's a lack of education, and that's something that we're trying to address. And I think also when we're thinking about specifically trans care, in the medical community especially, obviously we jump immediately to the medical side of things. So like when am I allowed to give this child these medications that are going to do all these things to their bodies that I'm going to have all of these feelings about, and that the research is still developing on. I kind of want to acknowledge that that's a focus of ours, but also acknowledge that gender affirming care can be done entirely without the medical surgical side of a gender affirming care model. And I think that especially with today's youth, gender is so much more fluid, as opposed to being in these two boxes of you're a boy, you want to be a girl. Can I help you do that? Is it going to be safe? And vice versa. A lot of kids are less worried about checking the boy box or the girl box and what parts they have, and a lot more focused on their gender expression. And you can assist a child in expressing their gender in lots of different ways without having to jump into the scary parts of our brains that are like, oh my God, like what happens if I, surgically alter this human, and then what are the repercussions? So just kind of acknowledging that that's a hot button issue for people, especially in our field and abroad, societally, but we can still affirm these children without having to go into all of the medical surgical aspect of things. So, and it's important too, because like these slides show, we're looking at the suicide rates, we're looking at the illegal drug use rates, and they are, I don't have numbers on this slide. I think there's numbers on another slide, but the lack of acceptance that they're dealing with is translating, obviously, to really poor health outcomes. We're talking also on this slide, the concept of being out versus not being out, and both of those being mentally stressful experiences that do still translate into poor health outcomes. And I think especially, for providers working with adolescents and with children, we do need to think about that coming out process, whether or not it's coming out as being gender nonconforming or coming out as being, not heterosexual, because that child is dealing with living in a heteronormative and cisgender normative world. And that time of coming out, I almost think about it as like, when we're working with people in abusive relationships, and we know that the most dangerous time physically for those people is when they're trying to leave the abusive relationship. There is an increased rate of actual violence, in addition to, mental and emotional trauma that happens around that coming out process. So that's an important thing to talk about with your pediatric patients, especially if you're starting to get those cues that they may need to be having a coming out experience with their family. And since in pediatrics, obviously, we're not just treating children, we're treating the family, providing that education for parents as well. Again, looking at these increased rates of different, looking at this vulnerable population, these increased rates of poor health outcomes, and understanding that we do need to specifically address, like in this slide, it's talking about specific like substance abuse programs, address the fact that there is gay-related stress, gay-related emotional stress that might be contributing to what's going on with them. And also backpedaling and understanding that being gay is not the entirety of their identity and not the entirety of what other, whatever substance abuse or mental health issue or poor health outcome is. Like, you can also be depressed and have it be nothing to do with the fact that you're gay or lesbian, but there's going to be contributing societal factors. When we're thinking medically, again, there are increased risks, health risks specifically for gay men. One thing that's always interested me in all my years of Planned Parenthood and all the millions of pap smears I've helped set up for my providers and things like that, that we never did anal paps. And knowing that there is this increased risk of anal HPV for men who are for men who are having sex with men, or anyone who's having passive anal intercourse. My providers always told me, like, we can do an anal pap, we can test to see if it's there. But at the time, they didn't even have protocols for what would happen if they found it. Like, we know what happens if you find HPV on a cervix, you get a colposcopy, you may need a LEEP procedure and on and on. But no one had set standards of care for positive anal pap smears in men or women. Again, just coming back to how charged that concept of coming out is, I think we already sort of touched on that, and needing to provide education and support in how to be accepting for the family, just as much as you're providing support for the patient who's sitting in front of you who might be struggling with coming out as any one of the LGBTQ letters.
And I want to just point out, Michael, that I've had several teenage boys who an uncle, when hearing that they were identifying and saying that they were homosexual, that the uncle would have forced rape by their girlfriend and say, well, we're going to change your mind. You just haven't had sex with a woman. And just this inability of a family to even hear these words, resulting in a rape of a teenager, that if it not shared with a friend would not have been reported to us, is we were not even seeing the warning signs of these things, just that this attitude and anger is so high in communities.
And yeah, I think that differs, that the lack of acceptance to that, I mean, that sounds pathological, that extent of not being accepting in that man. But yeah, we need to understand the communities that we're working in. Geographically, it's been a big move for me coming from the West Coast to Southern Louisiana when it comes to working, especially around, sexuality and understanding the population and understanding what the risks are for your patient who's in that vulnerable state of coming out. Obviously, like, rurality versus urbanness, there's all kinds of factors that are going to come into play that we need to be assessing what the dangers are for the patient. And this is some of the accepting behaviors this is when I'm talking about providing education for the family. This is some of the things that we're looking at as far as before children even come out, having the concepts of LGBT identity be present in their lives, in their consciousness, in conversation, providing positive examples. Maybe you think your child may be LGBT, or even for our children who are, 100% straight, like, we need to be providing these examples of LGBT identity so that they can go out and be allies in the world. So these are some accepting behaviors continued. I think it's really, really important, especially in our population down here, to think about that concept of the faith community. I've spoken to many adolescents and also many peers of mine reflecting on their adolescence and just the mental anguish of growing up loving your faith and loving the community that your faith provides for you, but also being told by your faith and your family and leaders in your faith that who you are is wrong. And that, I mean, it's hard to overestimate the damage psychologically and emotionally, I think, that can do to people. And I also have many patients and many peers who let that specifically that issue, the lack of support in their faith community and the concern about what was going to happen to them from a religious perspective led to suicide attempts. And then just, this is kind of just another thought of inserting this acceptance model into all aspects of the care that we're providing. So, we're providing training for our practitioners on how to provide this support for the families of LGBT children and all families. We're also including, like, when you're doing your advertising, when you're thinking about marketing and you're thinking about reaching out to patient populations, presenting these specific populations as people that you serve. I know Planned Parenthood, I think it was out of Maryland, did a really great advertising campaign, just being very blatant and forward and forthcoming about how they serve everybody, including the trans community, the gay community, and just creating that that visual. So specifically, I think it's easy to hear these, all of these numbers when it comes to how vulnerable these populations are. And sometimes you'll look at studies and it's the patient population is pretty small. But when we look at the larger studies, we're still seeing these astronomical numbers. This was a study out of Canada, and out of 6,800 polled transgendered adolescents, it came out with results of they are 5 times the risk for suicidal ideation and 7.6 times the risk for having attempted suicide. And this is another kind of putting the numbers out there just to try to ground it, because we hear big numbers and I feel like my brain goes kind of blank sometimes. But if we're looking at the actual overall population of, globally, specifically transgender, 0.5% of the population is going to present as transgender. And we're looking at 2 times the likelihood to think about an attempt suicide in LGBT youth, and 2/3 of trans youth reporting recent self-harm, 10% of transgender people recently attempting suicide within the last year, and over the lifetime, 22 to 43% of transgender people attempting suicide. So that's what I mean, this DEI training that sometimes just feels like a silly PowerPoint we have to watch at work. It needs to be looked at as life or death care. When I was looking at my review of literature, specifically speaking from the LGBT populations, the barriers to care that they were identifying tended to be overall, the largest one was unnuanced, undereducated, and culturally incompetent staff and providers. So running into that every time you have to go to the doctor's office, every time you have to go to the gynecologist, and that translating to no longer seeking medical care. Also, there were some, we like to think it's just a lack of education and people are really trying their best. But when we look at the extreme models of implicit bias and look at explicit bias, there are still many, many cases of providers blatantly refusing to treat patients in the LGBT community. One thing that I think is helpful, especially when we're talking about separating our implicit bias about the medical surgical aspect of transgender care, is just kind of starting to unhook the ideas of what gender and sexuality and sex is. I think this is a really helpful conversation that can be had at many different levels of childhood development. Like, this is a fun little experiment. Like, this is a fun kind of representation of these bigger ideas that gender identity is how I identify my gender to myself on the inside, versus my gender expression, which is how I express to the world what my gender is with my actions, my language, the way I dress. Like, this is whether or not I identify as a woman, even though I was assigned male at birth, and can I express that on the outside? Is it safe? Can I walk down the street in a dress? Or is that going to endanger my life? And oftentimes it does, unfortunately. And then again, unhooking the concept of sexual attraction from gender expression and identity. I think we're all pretty good at this point, understanding that just because you were born with a penis does not mean, you're gonna like girls, like blue, want to drive a truck. That there's all this nuance. And then being just specific when we're talking about sex versus gender as well. However, I went over a lot of this, but the one thing I do want to point out on this slide is the term genderqueer or gender nonconforming. I think that is the concept that I see most in our adolescent and pediatric populations is not necessarily, I still do have patients who are absolutely, I was born this, I don't want to be it, I want to be that instead. But there's a lot more fluidity. And I also see a lot of experimentation in gender expression. And I think that that's some of the data that we were talking about before, where you'll see a younger child and they're playing around with pronouns. And yeah, in a few years, they might not. They might settle into their assigned gender at birth. And so, yeah, of course, we don't want to jump in and start delaying hormone for the 7-year-old who wants to go by they, them. And we can do an entire conversation about what true gender dysphoria and transgender presentation in a patient looks like versus experimentation. And I think what it still comes back to is an affirming care model, an accepting care model is going to support all of these patients, whether or not they do end up post-puberty still identifying as transgender or gender nonconforming, or whether or not they don't. I always like to just kind of remember that these are identities. We're talking about who these people are, who we are, how we feel. And just to say I am transgender needs to be, it's pathologized. We identify this still as a disorder, gender dysphoria or gender identity disorder. I think if you were to identify as a cisgender woman, and what would the medical community say to you if you wanted to put a pair of pants on? Is that a gender identity disorder? So a lot of this is still evolving, and I'm excited to see where we are in the near future with the DSM and all of that. Again, this is what I was kind of speaking to as far as gender dysphoria, true gender dysphoria versus this experimentation with gender expression. And what are we going to do about that? Because if we're just jumping to medical surgical models of gender affirming care, then that's a lot more complicated than being like, yeah, hi, my name's Michael. I use he, him pronouns. What pronouns do you use? They, them. I can be supportive of you in your care and not have to worry about whether or not you're going to want to, go through gender affirming surgeries later in life or anything like that. I can look at the child in front of me and just create that affirming, accepting model of the medical and nursing care that we're providing. When we are talking about the surgical side, the medical side of things, we do need to still be acknowledging that there are risks. We also do need to, in medicine, we're always weighing cost and risk. Every medicine has a side effect. So yes, a man who does want to transition to becoming, to affirm his identity, his gender identity as a woman, is going to have an increased risk of VTE and all the things that are associated with high levels of estrogen in the system. He's also being put at risk if he wants to express his gender on the street and is not allowed access to feminizing hormones or feminizing procedures. So the risk of violence, does that outweigh the risk of, VTE and possible stroke? These are things that we have to look at individually for the patient that's standing in front of us and where they're coming from and what culturally and societally they're dealing with specifically. just the concept that, obviously we live in a heteronormative and a cisgender normative world. And I think the next slide kind of speaks more to this, the concept of someone who's assigned female at birth transitions to expressing their identity and, their gender identity as male, and then still becoming pregnant, having a baby, working in postpartum care. Here in New Orleans, it was very interesting watching the reactions of my coworkers when you're used to walking in the room and saying like, "Hey, mama, how was last night? Let me see that baby," and having to check yourself because the patient before you who just delivered doesn't identify as female. And so just again, creating that space in our heteronormative and our cisgender normative society and medical care for affirming this diversity. Just some takeaways again, like pearls for care. I always love to introduce myself with my pronouns, especially if I'm using my nursing discretion and I'm getting a vibe from a patient that they may be gender non-conforming. I'm especially going to make sure like, oh, hey, I'm Mr. Michael. I'm your nurse today. I use he, him pronouns. What pronouns do you use? Because I want to know. And making it sound normal. We go around every morning in behavioral health with all the children, and we all say our names, we say our pronouns if we want to, and you tell me, what color you're feeling today or whatever little check-in exercise we're doing, and just creating that normalization. And we're dealing with kids from very diverse communities. And it's really fun to see the process of education for kids who've never heard about they, them pronouns, coming from really more, just backgrounds that didn't expose them to those kinds of things, and them learning about and being supportive of their peers who are gender conforming, or gay, or, what have you. Thinking about our words as opposed to male to female, female to male, talking about assigned female at birth, assigned male at birth, thinking about how this translates into some of those legal aspects of gender affirming care, the way that we code, providers, the way that we code, and the insurance aspects of this is huge. So gender dysphoria, gender identity disorder versus some other ways to code for your transgendered patients. Also, just acknowledging when you've made a mistake and not hyper fixating on being perfect all the time. I've done this work for many, many years. I still misgender patients who tell me what their pronouns are, especially if I see someone in front of me who looks like they're expressing a gender that looks very female, let's say, but they want to use male pronouns and are expressing a gender identity that is more male. I slip up. And instead of making a big deal about it and being overly apologetic, just say, "Oh gosh, I'm sorry. Mr. Michael hasn't had his coffee yet." She or he, correcting myself and moving on to create that normalizing structure. And I can't read the last one. What's that say?
Letting your actions and words encounter serve as your primary form of letting them know that you care. And I have to say, where I find that difficult when you start talking about the pronouns is if you have a grandmother who comes with a child to the clinic, and I'm trying to use the pronouns that the child prefers, and then grandmom's referring to the pronouns that the child is expressing, I have to remove the person from the room. In my mind, it's too hard going back and forth between what the family members are able to accept and speak to and what the child's trying to tell me as well.
Exactly. And creating that concern for, again, this comes down to physical safety for a lot of patients. Like, okay, so your preferred name is Susie, your preferred pronouns are she, her, your family knows you as Johnny and calls you he, him. Do you want me to call you Susie in front of them, or do you want me to call you Johnny in front of them? Because I don't want to out you. Again, coming back to that sensitivity around the psychological and physical danger that can be present during the outing process. I don't want to out you if you're not ready, if you don't feel safe, if that's going to create more havoc later, because again, this can come down to serious physical safety issues among other types of trauma. So we really can't let our patients down when it comes to this. And I appreciate you guys wanting to be involved in this education process. And we have some resources.
Okay, thank you all for being here. Guys, it is now time for the Q&A portion. I will get my Q&A slide up for us. If you have any questions, feel free to put them in the chat, or if you are comfortable, you are welcome to unmute yourself to ask your question. Just ask that you be respectful and ask questions from a place of curiosity. Take the time to listen to the answers.
And Julie, I also want to invite, if anybody has a clinical example of some pearl that they have or something that they like to reference that's been helpful to them, we would love to hear that as well.
Okay, yes, welcome everyone to put your questions or comments in the chat, or if you're comfortable, you're welcome to unmute. Okay, I have one question in the chat. For kids for whom some medical management is indicated, puberty blockers, for example, what sort of legal/logistical recourse do we have right now in Louisiana?
I asked that question of the attorney from APSAC just yesterday, because that was one of the things that I anticipated everyone wanting to know. And her response to me was, that this point in Louisiana, that there is not the legal boundaries that you have in Texas. So from a legal standpoint, that is still a possibility. I don't have any other details, but from an attorney's point of view, Dr. Pasternak was the pediatrician that I knew that was working in that area, endocrinology at Children's. And I had not had a chance to talk to him to see if anything's changed in his practice. But from a legal point of view, the attorney told me that we are not bound by the restrictions that Texas is facing. And I know that they had Louisiana up as a no-visit state because there was an inability not only to get medications, but to get access to care and to be in a place where people felt like there was a great deal of prejudice.
There are bills that are attempting to move through our legislature right now that would change that.
Yes.
So do keep paying attention to your politics locally here. I know that University of San Francisco has published and has a lot of different resources for medical treatment protocols. So I don't have a specific person to reach out to them, but I know that they have they've done a lot of work in establishing treatment protocols.
Great. All right, next question. How do you handle respecting a minor's request to honor their sexuality/identity when their parents or guardians disagree?
You ask them, how can I help you the most? Like, do you want me to sit down and have a conversation with your parents about this? Because I can do that. You can be present or you don't have to be present. Or we can just, again, I mean, I'm not operating in a medical treatment sense. I'm operating in a behavioral and psychiatric treatment sense, which is a little bit different in my setting. But taking the patient's lead on that is important. I don't know exactly legally what.
The other things that you could do is to have bibliotherapy. I know at the care center we'll have pamphlets and books and information in the rooms while they're waiting, so that the parents can see that we have our rainbow flags up and that we have our information, and offer support groups or and just in terms of asking the parent, are you concerned about any behavioral things? Because sometimes the child has given the parent more clues than they think they have, and just encouraging the parent to be understanding of things, even if we put it in the words of, sometimes peers or kids this age go through these things, and I wanted you to know there's resources. And there's whole books out there on how to, once a parent is accepting of it, how a parent can write a letter to a school to be accepting for their child, how they can approach other family members so that you don't have to start from scratch. And how do we tell grandmom? So it's like mom and dad become allies, and then the book will give you ways to, the verbiage that's not off-putting. Well, it depends on the person's receiving it, but it is less off-putting in terms of you just quietly state how things are going to be in your home and what you would anticipate them doing and when they interact with your child, but it takes away some of that emotion, and having them role play those things can be very beneficial. So getting a little counseling prior to coming out to the rest of the family or to the school. But definitely, as Michael's saying, taking the cues from the child's need for and readiness for those things
And
to happen.
so, yes, exactly. And like, obviously creating that space confidentially to ask those questions. Adolescents, I think you can kindly ask the parents to step out of the room at some point and have a discussion with them.
I don't see any other questions right now. Oh, there we go. Will we get y'all's email contact? They'd love to have y'all give, Dr. Bouquet would love to have you give a lecture with a deeper dive into the up-to-date types of care for our queer community, including like anal pap smears, etc. She's faculty at Our Lady of the Lake Peds residency. So I can do an email introduction if that works for you.
That would be fabulous. And thank you.
Yeah, absolutely.
I appreciate that opportunity, and it's wonderful. I wish we were in a room together where we could talk more personally, but I love that you got this together, Julia.
Thank
You're
you.
incredible.
Okay, are there any other questions or vignettes or cases that you've seen in your practice that you'd like to discuss? Okay, I'm gonna go ahead with my announcement slides, but if you have any questions, feel free to put them in the chat. I will keep monitoring that. Okay. All right, first thing to know, make sure to claim your credit by completing the evaluation for this webinar. The evaluation is how we know that you attended, how we know that what you liked or didn't like about our education opportunities. It helps us to continue to improve, and additionally is required to claim your credit because we need more information than what we have from you so far. So you can scan the QR code here, and I will drop that link in the chat. Let me get that over here for me. Okay, I'm going to drop all of the links that I have coming in the next couple of slides in the chat in one block. Next up, our on August 16th through 18th will be our next conference in Alexandria, Louisiana. The early bird registration will end on June 30th, so make sure to take advantage of that best price of the year. You can learn more and see our full agenda at laaap.org/2024 potpourri. Our next and final webinar in the Pediatric Gumbeaux series will be on June 27th with Dr. Pinky Prasad, taking care of the childhood cancer survivor. What do I need to know as a pediatrician? You can register there. You can register for this webinar where you registered for the current webinar that you're in, pediatricgumbeaux.eventbrite.org. If you're a chapter member, you'll see this come through your email a couple of times before the webinar starts. And then finally, you can access all of our recordings of the previous webinars in this series and claim on-demand education by going to our YouTube channel or our Louisiana AAP education page. This link will take you right directly to our YouTube channel where all of the webinar recordings are. And we process that credit so you can get your CME credit even if you can't attend live. This webinar should be processed shortly. I'm about to go out of town, so it might be a little bit more of a wait than usual, but we will have this edited and put up on our channel and on our page pretty soon once I get back. All right, does anyone else have any questions? I don't see anything new and I don't see anyone unmuting. So thank you all for being here with us today. I'm going to take a minute to invite our new executive director to unmute and to introduce herself.
Thank you so much, Julia, for having me. Hello, everyone. My name is Natasha Cheatham. I am the new Executive Director for the Louisiana chapter of AAP. This was my first Gumbeaux webinar series. I would like to thank our speakers for an amazing presentation and welcome all of you to join us for our next engagement. But thank you guys so much.
Okay, thank you, everyone. Thank you, Dr. Troy and Mr. Cooper.
Thank you.
We
Thank you.
will hope to see you all at the next webinar and at our conference in August.